Well, I'm Kathleen Schultz, and welcome. Thanks for coming tonight, especially with it so being nice out there. Oh my gosh. So I appreciate that you all came tonight. This is the first in our orthopedic movie night series that we're doing here at Riverview. So we got some others coming up, and I have information about our next one on your chair as well. So welcome. Thanks for coming to our discussion tonight with myself and Dr. Wilkes here. So as we get started, we're going to have a next one at the end of August, and then some others throughout the year. Different topics. There's many topics in orthopedics, so we figure we can come up with something each time that you'd be interested in. And we're going to be tapping into our experts out at Wisconsin River Orthopedics, the orthopedic surgeons. Each one is going to do a different night as we go through the year, so that should be pretty exciting. So we're anxious to get going on this. So we're happy to do that. But whenever you come to any movie, you always got to start out with the dancing hot dogs and popcorn, right? So as a joint care coordinator here at Aspires Riverview, what I do is I work with patients having joint replacement. That is one of my jobs, and I work with them before surgery, while they're here in the hospital, and after they transition home as well. But I have other jobs under my hat, and one of them is education. I do a lot of education here at the hospital about joint pain and treatment options, and I also do that within our community and surrounding communities as well. And so I really enjoy that piece of it, so I'm excited to be part of this tonight. Another job that I have under my hat is that I keep track of a lot of quality data on our patients that we do here at Riverview, because we want to ensure that any patient we take care of is having excellent outcomes. And so I'm happy to report that we do have very successful outcomes here in the Joint Center. And I'm always excited to share that. Many of our patients, 99.8% actually, go to their own home after surgery, and they do so much better in their own home. You know, Dorothy was right back in The Wizard of Oz. There's no place like home. There is less risk of infection, and people just getting up and walking within their home is therapy as well in itself. So it really helps to get people back to doing what they enjoy doing after joint replacement as well. We're also ranked #1 in Wisconsin for many areas of joint replacement, which we're very excited and proud of. But we want people to have very successful outcomes. So I'm happy to report we are well above the national average for range of motion afterwards and the distance people walk on the day after surgery. We also are below the national average, way below, for surgical site infections and readmissions to the hospital after joint replacement as well. But what I'm most excited about and most proud of is that our patients rate us as excellent. On independent surveys, we have nothing to do with the surveys, but they call and talk with patients afterwards, and they're rating us very high, and we are very excited about that. And actually, they're recommending us to people throughout Wisconsin. We see patients for joint replacements from all over. We've even had some people from northern Illinois that had relatives that had retired up in this area, and they told them, oh, if you're going to have a joint replacement, don't do it down there, come up here. And so we're very happy about that and very excited that our patients are happy with the care that they received here and their successful outcomes as well. But with joint pain, joint replacement isn't always the treatment option. So we're happy to have Dr. Wilkes here tonight that can talk about many treatment options. But a lot of times people think that, oh geez, it's just part of aging, that I wake up in the morning and my joints are stiff, I can't move, I just can't do all the things I used to do. But that decrease in motion and that stiffness isn't something you have to live with. There are treatment options out there for you. And but how do you know where to start? Well, you start with seeing an orthopedic specialist. Find out what your diagnosis is. What is the problem? And then find out treatment options that can help you get back to doing all the things that you enjoy and like to do. On your chairs tonight, I included one of our brochures, and it's a guide to an orthopedic evaluation. So when you go to see an orthopedic specialist, you're like, oh geez, what's he gonna do? Well, that kind of helps you through it. And it has questions in that brochure to kind of think about what, you get to a doctor and you're kind of nervous and you got that white coat syndrome going on, and And they ask, well, they start asking all about your pain. When did it start? When is it worse? What's your number? What's this? And at the moment, you're like, I can't think, it just hurts, So hearing those questions, reading through in that brochure can start you thinking about what they're going to ask. We want you to get the most out of your visit with your orthopedic specialist. And so by using that guide, it can kind of help you with questions to think about beforehand before you get there. There's space in there too to write questions as well, and suggestions of questions that you want to ask your orthopedic specialist to make sure you get the best out of your visit with them as well. But that is the best place to start. Get that diagnosis, find out what's going wrong, and find out what treatment options that there are for you as well. So we're going to get to the orthopedic specialist, and Dr. Wilkes has a wealth of information to share with you tonight. I've been at Riverview for 35 years as of Tuesday, and so that's a long time. We've been doing joint replacements well before I got here 35 years ago, and Dr. Wilkes, I think, has been here
31.
Right after me. So yeah, so together we've worked closely for a long time, so I know this man has much information to share with you. So to introduce him, I have our movie for the movie night, okay? So hang on to your chairs. I got to do technology first. And I'm not sure Dr. Wilkes has even seen this yet.
I haven't seen this, no.
Originally came here 29 years ago, so I'm in my 30th year of practice. Went to medical school in Milwaukee at the Medical College of Wisconsin. I went into orthopedics after having done a 2-week rotation because I saw that it was problem-focused medicine. So I saw gratification by the patients getting better. I saw gratification by the physicians that were treating them because they saw the results more immediately than long-term chronic illnesses. Well, I like seeing a patient and delving into what the problem is and educating them once I have a diagnosis for them. It really is educating them so they know their choices. It isn't an emotional decision for them then. And then supporting them with whatever option they feel is the best treatment for them. Well, I had a gentleman that had severe old legs. We call it varus knees. He loved to ski. And it's to the point where he couldn't ski. I replaced both of his knees. He sent me a card thanking me and a picture trout fishing with his waders on before the surgery and after the surgery. He told me that he's 2 inches taller, and that was his 67th day skiing that year, 2 years after his knee replacements. That was very rewarding. I still keep that picture. One of the most fun things for me is being in a small town, you got to be willing to be available all the time. When I go into Ace Hardware, I run into patients. One of my hunting buddies, I've replaced both of his knees. Now he's back being a good hunting buddy again.
All right, so with that, we're going to introduce Dr. Wilkes.
Well, thank you, Kathleen,
He's
for
gonna
asking
take
me
over.
to be here tonight. I argue that this type of thing is for you guys, not for me. So I like it to be less formal than a formal presentation. I like it to be more that as I'm presenting a few things, I invite questions anytime. Shout out or raise your hand, whichever you're more comfortable with, and I'll address any questions you have along the way, because again, I'm here to try to help you be educated or learn about some things. One of the things that Kathleen pointed out is the success rate here. The biggest help of our success rate, while we have low complication rate and a low infection rate, is we have a good crew in this operating room at this hospital, that we don't have a changeover. We have the same people that have been here for a few years. They've been well trained along with us, and those same people are doing the joint replacements with us. We aren't getting a new employee today and then a new one 3 weeks from now and a new one 6 weeks from now. We have consistency with the staff here. And that's so important. And that's so important with the joint camp, the way Kathleen runs it, that we have nurses that are well trained at helping patients after joint replacements. The physical therapists and the occupational therapists are also consistently the same people helping out our patients. That makes it a lot easier for the patient, but it also instills a comfort level with the patient, that the patient sense people have had this experience and they have a confidence level that they know what they're doing. And so I really applaud the whole team, because that's what it takes. We're one of the cogs as orthopedic surgeon. The patient's another one of the cogs. The nurses, the surgical techs, and the therapists are all part of the cogs, and everybody has to do their part to get those outcomes. So those outcomes should really represent the community and the hospital and the nurses and the therapists. So really feel good about that because of what we've done here, and a big part of this has been Kathleen running this joint camp. I wanted to talk a little bit about what orthopedics is. On the left is, in the picture on the left is Nicholas Andry, And orthopedics, the name ortho stands for bone, and pedics comes from children. So Dr. Nicholas Autry was a pediatrician. The first orthopedic surgeons, if you look at any symbol you see of orthopedic surgeons, it's a crooked tree being splinted by a stick next to it. The international symbol is a maple tree. We took a white pine tree because where we live, if you look at our clinic, there'll be a white pine tree that's splinted by a stick. So we were the doctors that splinted children's crooked legs and arms. That's how we got started. And the first surgeons were the barbers. If you wanted to have something like a wart or something removed or something wrong with your hand, you went to your barber, sat in the barber chair, and they were the ones talented with sharp instruments. So we really have derivation from pediatricians that was splinting crooked children's legs and barbers that were doing surgery in their barber chair. And that's, the right-hand picture is just that, showing a barber doing some surgery. Kathleen, which button?
On the right.
On the right, okay.
There you go.
So arthritis, arth means joint, itis means inflammation, just like tendonitis means inflammation of a tendon, arthritis means inflammation of a joint. When we replace joints, we call it an arthroplasty. Again, arth means joint, plasty means changing the shape. So let's talk about arthritis. Arthritis truly doesn't mean necessarily wearing. That wearing out or degenerative joint disease or osteoarthritis is one type of arthritis. Any inflammation of the joint is arthritis. Gout causes arthritis. Lyme's disease causes arthritis. Rheumatoid arthritis causes arthritis. You can have post-traumatic arthritis from having had trauma or a fracture in the joint. So the term arthritis just means inflammation. And it's one of the most prevalent conditions that affects people in the United States of America. And there are more than 100 different diseases that cause the different types of arthritis. The most common cause of disability in the United States. The two most common types of arthritis that affect or inflammation that affects the joint is osteoarthritis and rheumatoid arthritis. Rheumatoid arthritis is a genetic thing, and it's a disease or a condition where your own immune system attacks your cartilage. So it isn't the gradual wear and tear of a joint like osteoarthritis. Rheumatoid arthritis is, some people get it as a child, called juvenile rheumatoid arthritis. Some people get it later in life. A lot of people in their 40s get it. It affects many more women than it does men, and it creates a situation where instead of getting spurs and things around your joint, you actually gobble up your own cartilage. Your body thinks of your own cartilage as being like a sliver and wants to get rid of it. So that's a separate condition that's usually treated very early in the condition with medications and being seen by a rheumatologist. Remember way back in the past, it was treated by gold shots. I don't know if any of you remember hearing about gold shots. Gold was used to reduce the inflammation of that autoimmune condition, rheumatoid arthritis. Osteoarthritis, which is what most of us have, it's inevitable we all get some of it, and the rate that we get it is different. Osteoarthritis is the gradual wearing away of the cartilage on the end of your bone. Just like on the end of a chicken bone, we have that white cartilage cap on all of our joints. When we stop growing, ladies, 14, 15 for you, us guys, 16, 17, when we stop growing, we stop making that cartilage. From that point forward, you start wearing out that cartilage. So again, think of it as a tire. Genetically, the most important factor, whether your cartilage of your knees, let's say, as an example, wears out or lasts you your whole life, is what genes did you get from mom and dad? Did you get Pirelli racing tires or Fleet Farm tractor tires? They're both a set of tires, but one's going to last a long time and one isn't. Other factors that contribute to the wearing of the cartilage is activities that we've done, any injuries such as fractures or cartilage damage or ligament damage to a knee, weight we carry around, the type of work you've done. Of all of those factors, the most important thing is truly the genes you inherited from mom and dad. I have very skinny, slender people, age 80, with good thick cartilage, no wearing out. They got the Pirelli tires. I've got 50-year-old gentlemen, the other person was a heavy person with very good cartilage, and I've got people that are very, very skinny and worn out joints, and they got the Fleet Farm tractor tires. So the most important factor is the genes you inherited. Now, when you have arthritis and you have wearing away of the cartilage, you have pain because there are nerve endings in the bone that are no longer protected by the joint, and you get inflammation, and that creates fluid and therefore stiffness in the joint. And that's where the pain comes from, is from the inflammation. The medications that we use, such as ibuprofen or Aleve or diclofenac, any of the NSAIDs or non-steroidal anti-inflammatory drugs are trying to treat the inflammation that's caused by arthritis, either rheumatoid or osteo, and therefore get rid of the cause of the pain. If we reduce the inflammation in someone's knee or hip, they have less pain. So that's always early in the course of treatment, you try to be conservative and try to get people relief by doing less invasive things and being on some medications like anti-inflammatories. Rheumatoid arthritis, again, I mentioned that a little bit. It's an autoimmune disease. It's where your own immune system doesn't recognize your own cartilage as being you. It thinks of it being as being foreign. It attacks your own cartilage, attacks the membranes. People get very crooked fingers because those joints are very easily involved. When people have rheumatoid arthritis, since it's an autoimmune system, it's a systemic disease that you have in your whole body. So usually it's 7 joints or more involved. Where osteoarthritis can be 1 or 2 joints. And usually rheumatoid arthritis, if you have it, it's bilateral. So if it's your right wrist, you also have it in your left wrist. If it's your right knee, you also have it in your left knee. So some of the signs are, again, many more joints always, and usually very symmetrical. There are no specific over-the-counter drugs for rheumatoid arthritis. Again, we treat non-steroidal anti-inflammatory drugs. For pain, ibuprofen is always a good option for pain in addition to the anti-inflammatories. Most common is osteoarthritis. 33 million people in the United States are affected by it. It can occur at any age, most likely over 60 years of age. This is an example of a hip on your left. These are x-rays, and this is the ball of your socket. This is on your femur bone, which is from your hip to your knee. And here's the acetabulum, or what we refer to as the socket of your pelvis. This space from here to here is cartilage. It looks like a space because your bones have calcium in them, and they look like white on x-ray because there's calcium that blocks the x-ray. The cartilage has no calcium, so it looks like a space. Does everybody see that space between the white? Here's a worn out hip, and this is osteoarthritis. If you look here, there's a little bit of space right here and a little bit right here, but otherwise it's bone on bone. And there's a spur out here, there's a spur out here. Spurs are your body trying to immobilize the joint. Our body, Mother Nature knows that if you have a worn out joint, it hurts to move. So your body starts growing spurs to stop the joint from moving as far. And one of the symptoms that'll bring people in because the pain comes on gradually is they'll say, I can't cross my legs anymore. Or I can't squat down and pick up my grandchildren anymore because the joint motion just isn't there like it used to be because of the spurs. Also, what starts to happen is instead of that bone or the ball of the hip being nice and spherical like it is over here, nicely mated into a spherical cup, you look over here and there are flat spots on it. So instead of being a nice round ball that rotates in a bone and round socket, there are flat spots that it will get to a certain point and it won't move any further. So that's an x-ray of osteoarthritis versus a normal hip joint. We all started out with that on the left, and at a different age, we eventually get some element of what's on the right. With osteoarthritis, though, sometimes people will wear out their knees and they'll have great hips for their entire life, or vice versa. It doesn't have to be every joint. But the most common joints involved with osteoarthritis are the weight-bearing joints, hip and knee. Shoulder also gets it, but not to the degree that hips and knees get it. Here's a knee joint. Again, using what I mentioned earlier about a space between the upper and lower bone. This is the femur bone. This is a front view of someone's knee. You can kind of see a vague round circle right here. That's the kneecap sitting on top of the femur bone. And this is the tibia bone. Nice cartilage space. Very normal looking knee. This is like the extreme over here. This person is very bow-legged. This is the side of their knee toward the other knee. You can see how the bone comes down here and angles over. And so that's like that. And I talk about that to patients being comfort bent for riding horses. If you're a cowboy, it's a good deal, but if not, it's not. Bone on this, I'm sorry, I described this, I'm looking at the film backwards. This is actually not knee because it's worn on the outside. Cartilage still here, it's a reverse x-ray than that. But bone on bone here, and you see how white it gets? When you bear more weight on the bone because the cartilage isn't there anymore, your body senses more pressure on that bone, so it puts more calcium into it. And so this really worn out side get very bright white because there's more calcium in that bone, again, in reaction to the wearing out and the stress on that bone. Okay? Symptoms of osteoarthritis. Sometimes the joint can be warm when you touch it. Sometimes you'll feel swelling or water on the joint is a common term that patients use. You get stiffness, especially in the morning, and again at the end of the day after you do more. You get up and get moving, the osteoarthritis stiffness tends to be better, but if you overdo it, go out and mow the lawn, do a bunch of things, it gets stiff. Also, if you take a long ride in the car, you go to get out those first few steps and it's like Festus from Gunsmoke getting out, right? You get decreased activities. It affects the ability to ascend and descend stairs, and usually it's going down the stairs that hurts more. Because if you're going down a stair, it's harder to lower your weight carefully without letting it go than to push up and lift upwards. So usually people will complain of going down the stairs bothers them more or earlier than going up the stairs. They talk about impaired lifestyle, grasping and holding objects. That's more if it's in the hands and elbows, okay? And you get deformities of the joints. Again, if you wear out the inside of your knees faster than the outside, you get bow-legged. If you wear out the outside, you get knock-kneed. Normally, 90% of the population wears out their inside first. I'm bone on my inside. I need knee replacements. My wife is bone on the outside. She's special, I knew that. She's in the 10% that wears out the outside faster, okay. The difference is people that wear out their outside faster get knock-kneed, like this if you will, but they maintain more of their motion. For some reason, wearing it out the outside faster, people still get very good bending or the ability to flex their knee. Where if you wear out the inside, you rapidly lose the ability to bend your knee all the way. And eventually it gets bad enough because of those spurs that you can't fully straighten out your knee. You feel like when you're laying in bed that you can't quite make the back of the knee hit the mattress. Biggest issue is pain, stiffness, and a decrease in joint motion. Arthritis treatment, there is no cure. Research right now is trying to find ways to grow cartilage. We can take cartilage from your knee, we can send it to a lab, and we can grow it in a petri dish and try to put it back in, but it's right now in the experimental phases. It's not going to happen in our lifetime. That's going to happen a generation or two down the road that we're going to see things like that. But that's where the research is going. What can we do to replace the cartilage with living tissue rather than metal and plastic? Exercise on joints, you think is counterintuitive. You think if my knees hurt, I shouldn't do activity, but actually it helps it. Motion, like Kathleen said, motion is lotion. Moving helps the joints do better. And patients say, well, I can't walk a whole lot. I say you need to substitute biking or swimming for walking. When you're in water, your body's partially buoyant, so when you do activities, even if it's exercise in water, you don't have this much of a pound weight on and weight off as when you're walking. The other thing is elliptical or a bicycle, because again, you don't have the weight pounding on and off like you're walking or running around a treadmill. So those activities are activities that people can do to stay active. Healthy diet, weight loss. Once you have a worn out joint, excess weight really aggravates it, and if you can lose weight, it's important. There's a big trend away from doing the joint replacements on people with excessive BMIs because of the complication factor. Right now, there's almost an absolute across the board in the United States. If someone's BMI is over 45, they won't get a hip or knee replacement. A lot of us are saying 45 for a knee. If your BMI is over 40 for a hip, that's your body mass index. You aren't a candidate either. You have to lose weight first. And it's not being mean. It's if you carry that much weight, it is harder to get into that joint because you're heavier there, and you cut through more fat tissue. Fat, when it's cut, becomes liquefied and has a greater risk of infecting the joint when you do that, when you have that operation. It's harder to get into the joint and line it up as well for the surgeon, but also that extra stress on that artificial joint over time wears the joint out faster than if you don't carry that extra weight. So there's a real push to get weight reduction as an important part of treating people before they have their joints replaced. Weight-bearing joints, hip and knee. Ice helps. Ice is always, or ice is never wrong. Heat is often wrong. So when things are worn out and they hurt, icing, icing, icing. acetaminophen or Tylenol, non-steroidal anti-inflammatory drugs, and topical creams. There are anti-inflammatory drugs that are now a topical cream that if people have stomach upset or bowel problems with taking non-steroidals, we can give non-steroidal cream that gets absorbed through the skin, and you place that on the knee joint 3 or 4 times a day. Works well for the hands, works well for the wrists, elbows, knees, and ankle. And it's a way of not putting an anti-inflammatory through your stomach and through your gut, where it can cause problems for people that have ulcers or previous problems with non-steroidals. Plus, if you're on blood thinners, Coumadin or Xarelto or any of the anticoagulants, you can't be taking non-steroidals, but you can use the non-steroidal cream because it's not that much getting into your whole body. It's just going to the joint that you need it. So those are another option for people. The anti-inflammatory gels. The main one right now is Voltaren, or the other name for it is diclofenac gel, and it works very nicely.
Dr. Wilkes, is that prescription?
Pardon me?
Is that over the counter?
It's prescription still, yeah, it's prescription.
Okay.
And you have to use it regularly. It can't be, I hurt today, I'm gonna put it on. You've got to use it 4 doses a day. You put the first dose on in the morning, a minute or 2 later put the second dose on. Then a single dose at supper time, a single dose at bedtime. And it takes 4 to 6 days of using it before you get really the effect. The second or third day, the skin feels a little bit different. Not uncomfortable, you notice something going on. But it takes 4, 5, 6, even a couple days longer than that to get the effect into the joint to get enough in there. The way anti-inflammatories work is they stop your body from producing the chemical that makes the inflammation. It doesn't get rid of the chemical that's already there making the inflammation. It stops more from being produced. That's why you have to take it regularly for a period of time. It isn't like, I have a headache, I take my Tylenol and my headache goes away. You have to have enough in your blood system to lower the normal chemical called prostaglandin that your body makes to create the inflammation. One of the things that I'm really big on telling people about is if you have a fracture, quite often I'll see people from the emergency room with a broken wrist, and they're told to take ibuprofen or Aleve. I really recommend not doing that because studies have shown that it gets rid of inflammation. It slows down fracture healing. So we don't want people to not have the inflammation that they need to stimulate the fracture healing. Different if you're treating osteoarthritis or rheumatoid arthritis. Okay? Any other questions? My voice carry okay? Okay. What happens when we see you? The most important thing with evaluating a patient is, when does it hurt you? What kind of pain do you have? Is it catching, snapping, locking, or achy pain? Is it stiffness? Is it loss of motion? Does it stop you from doing work activities? Does it stop you from doing recreational activities? I always ask patients, what do you like to do for fun? And a lot of patients say, I don't do fun anymore, my knee hurts too much. Then the next question is, what would you like to do if your knee didn't hurt? Because you want to see, can we get this patient back to the lifestyle that they want? Okay? Now, if someone wants to go back skydiving after having worn out knees, probably not the best idea, but certainly downhill skiing, that gentleman I talked about that skied that many days, he fought World War II. He was the 1st Infantry Division trained out in Vail, Colorado, and I was so happy to send me this picture. His son sent me a picture of his knees like this, trout fishing in his waders, and the knees straight, trout fishing in his waders 2 inches taller. And I skied, 67 days this year. It really makes you feel good when you got an 80-year-old that's back skiing, That's the extreme. If people get physically active again, you can get back into doing the things you want to do, okay? With artificial knees and artificial hips, there aren't a whole lot of restrictions in regards to activities. I'd rather see people bike ride and do elliptical and swim than run, sprinting, because of the pounding on the joint. But we can get people back into most activities. So the x-rays show, as we saw in those x-rays, the joint space gets narrower and you lose that nice cartilage cap on the bones. Important parts of treatment that we discussed, weight loss, very important part. Even before you have the joint replacement done, if people lose weight, their joints that are worn out will feel better and quite often last them longer before they need the knee replacement or hip replacement. The later in life that you actually have the joint replacement done, the more likely it is to last you your whole life. It can be redone a second time, but it's never as good as the first time it's done. These components are modular, and so we can take out a portion of them. If the plastic wears, we can take out the plastic portion, pop a new piece in. But it's still a major operation to do that. Weight loss helps it. The average artificial hip or artificial knee, I tell people 90% lasts 20 to 23 years or more. That's in a 65-year-old that's not morbidly obese. Go younger, and it's not going to last as long because a 50-year-old with an artificial knee or hip wants to do what all 50-year-olds do. A 60-year-old wants to do what 60-year-olds do. So you got to realize the earlier in life that you have it done, the likelihood of it lasting as long is a little bit less. And the weight is a big factor of that also. Okay? Other things that we do for things like hip and knee joints is sometimes we do cortical steroid injections. Remember we said the medication like Aleve and ibuprofen and Advil and Nuprin, all of those are non-steroidal anti-inflammatory drugs. They're called that because they're trying to get rid of inflammation like a steroid does, because the gold standard or the best drugs to get rid of inflammation are steroids. Well, we don't want to be taking steroids by mouth because it affects everything in our whole body. Only in a rare occasion do you want to be taking steroids. So we want non-steroidals to act like the steroid, but the best drug for getting rid of inflammation is cortisone or prednisone. Injecting them into the joint doesn't have the problems of taking it for several days as a pill form that affects everything in your body. Steroids are a normal chemical that your body produces to help you get beyond injuries, get beyond inflammation. So corticosteroids is a class of drugs that we can inject in knees, and you can have up to 3 in a year in the same joint. And corticosteroids get rid of inflammation. Sometimes we aspirate a knee if there's a lot of fluid or that water that I talked about before. Take the fluid out of the knee and replace it with some cortisone. Again, that can take 4 to 5 days to start to work. Knees we do in our office, hips we have to do under x-ray and it's seen. Sometimes a couple of us will do them ourselves under moving x-ray, a couple of us send them to the radiologist to do them under x-ray. And the reason for that is you have to be sure you're in that joint, so they put a needle into the hip joint, squirt a little bit of dye in, and under the moving x-ray they can see that that dye is in the joint, so the cortisone can go in right afterwards and be in the joint. When you do a cortisone shot, you try to predict when you see a patient with their joint, will it last them long or not last them long? And the best indicator of it is if they had a shot before, how long did it last? If it lasted 9 months, a good chance that the next one's going to last a long time. If I did someone 6 weeks ago and it lasted 2 weeks, I'm willing to do a second one, but chances are it's not going to last very long. If they've had 2 cortisone shots and so it lasted 2 weeks each time, I find it hard to convince myself that I should do a 3rd shot. One of the other options then is called hyaluronic. It's a chemical that comes from the comb of a rooster's head, or it comes from shellfish. It is like water is a little molecule, H2O is a real little molecule, so if you squish down something hard on top of water, the water all squirts out. Hyaluronic acid or hyaluronic is a big long carbohydrate, a big long chain molecule. You can't force it all out from between the joints, so it's a slippery material that's thick, kind of like Caro syrup consistency. You inject that in the knee and it's a series of 3 or 5 shots. There is a version of it that's a one-time. The one-time shot version is not as good as the series of 3 or 5. And so you have a shot a week for, let's say, 5 weeks. That's the one I use in my office. And people get 6 months, some people get 9 months relief from it. Some people only get a few weeks. Again, you don't know until you try it on that person how much relief they're going to get. Okay, so it's another tool in our armamentarium that we can use to help people with a non-operative option to see if we can buy some more time. If I make someone's knee less painful, and they can be older, they're going to have that joint last longer. If I can make their knee less painful and they can do more activities, their joint is going to be better too and they'll lose some of the weight.
How do you help the patient decide which is an option?
You talk about both, and I often will, the cortisone shots, almost every insurance company pays for them. Some of the insurance companies will not pay for hyaluronic, so we have to get approval from the insurance companies. Right now, Security Health isn't paying for them anymore. This is a decision that they made, unfortunately. And sometimes the insurance companies will pay for them, but only if you fail the cortisone shots. But if anyone comes into the office today, and I can do a cortisone shot today, it'll be covered. The hyaluronic quite often has to be approved ahead of time. Some of them we have automatic approval, we don't have to call in, but we have a list of those That's too important. My staff tells me who I can do it on and who I can't. Okay.
Question for you. On that your rooster comb, basically injection, I actually had that done. How do you do that?
How do I do it? Physically, how do I do it? Have the patient lay on the table, we scrub up their knee, okay, and I spray ethyl chloride, which is a chemical out of a bottle that hits the skin and evaporates so fastly that it gives you a few seconds of numbness. I can put the needle through that and we go right above the kneecap on the outside.
Do you, when you inject it, do you have like an x-ray or anything to show
No,
where that's
you
going?
shouldn't need that. None of us in our office use ultrasound or x-ray for that.
I had that done in both knees. And
At
this-
Wausau.
No, that was right here in town.
Really?
And this left knee was so bad, I could hardly stand the pain. It was like they went into a tendon or something here.
They might have hit, remember you were injecting into a joint that's inflamed. And that joint, think of that sac around the joint as a water balloon. But if it's really inflamed, it gets lots of folds and thick areas of the water balloon, so you stick a needle in. Sometimes you're not into the cavity of space. Sometimes you're in the tissue or the fat pad that's behind the kneecap. And that hurts more to have it injected. Yeah.
If
Yes.
you have that the second one,
Rooster coon, yeah, yeah.
and it's one shot,
No, you won't start crowing in the morning.
well, that's,
You won't start laying eggs.
can you have that repeated?
Yes, you
If you go
can.
through the first 5 shots? So it's
Medicare rules are 6 months.
Okay.
And most insurance companies bow to the rules that Medicare has about this, especially if it's a supplement. People go, well, I have Medicare, but I have a supplement. Supplement follows Medicare's rules.
Okay.
So with Medicare, it's usually 6 months.
And that's a
And-
treatment that's covered by Medicare?
Yeah.
It is, okay.
They view it as this, not necessarily whether it's the right thing or not, but it's cheaper than a knee replacement, so if we can save them a few of those, they're all for it. I mean, that's the reality of it, right? The reality of it is an artificial knee, all said and done with x-rays, artificial joint, therapy, hospitalization, rehab, crutches or a walker, you start adding everything up, you're looking at $25,000 to $32,000, start to finish, okay? Hyaluronic acid, the series of shots is $1,000. So Medicare says, if we get 30 of these, it's cheaper than one knee replacement, then 5 of those people only end up getting knee replacements, we're all for it. I mean, that's the reality of it. I argue, I tell my patients, you will know when it's time to have it done. There was a movie in the 70s called Network. Anybody remember that movie? They all went there, it was all about a TV series, and they all got mad and they went to their windows, threw open their windows, and they took their TV sets and said, we're mad as hell, we're not gonna take it anymore. They threw the TV set out the window. That's like the artificial joints. When you know that your joint's bad enough, you're gonna throw the TV out the window and say, I'm not taking this anymore. You try things. You wear shoes that give good cushioning. Sometimes I have heel cushions I give people to help absorb the shock of walking so their knee doesn't get as much. You use a running shoe rather than a walking shoe, things like that. So there are those options, but the injections are a good tool. And a patient is the only one that knows the barometer as to how much pain they have from their worn out joint. And you have to be cognizant that what they need and what they want. I always tell people, you will know when it's time. I don't have to tell you when it's time because I don't treat your x-ray. I treat your symptoms. If you're hurting enough, that's the right time. And I'll have x-rays that are barely bone on bone, not like that one knee that was really bad, that they say, I can't put up with anymore. Now, people that are really bone on bone, they say, I'm still going good. You know, so again, one of the factors is their x-ray, one of the factors is their exam, one of the factors is how they feel. The most important factor is how they feel. Can I live with this or not? Next question is, do I want to live with it or not? And you know what the alternatives are. To be taught the alternatives helps you decide whether I'm ready to have that or not. Okay? Any other
Use that on the
questions?
hip too?
What's that?
Can you use that on the hip also?
Most of us don't do for the hip. There are people that do it on the hip, but it's not as effective. It's truly the best is the knee.
Is the knee.
It's not indicated for shoulders or elbows, but it's the weight-bearing joint. But it can be tried. I have never ordered it. I use a lot of that in my office for knees. I've never ordered for hip, but if someone said that they wanted to try it, I'd be willing to no, I'm after whatever it takes to help someone be more comfortable. Again, we're treating the patient, not their x-ray. Okay?
Yes.
Is age a factor as to
Pardon me?
Is age a factor as to the treatment that you give?
Is age a factor? Someone that's, technically, if you're healthy, that trumps numbers of years of age, okay? So if you're talking about whether you have surgery or not, I sit down and talk about the risks of surgery, which is the risk of infection, risk of a blood clot, are the two major risks of hip replacement, knee replacement surgery. We give people antibiotics at the time of their surgery and for 24 hours afterwards to reduce the chance of infection. We put people on blood thinners, sometimes aspirin, sometimes an injectable, sometimes a tablet. All of us use different treatments for preventing blood clots, and the pretty white socks that look like tights. But a blood clot that breaks off and goes to the lungs can be fatal. Okay, I've never had that happen. 3,000 knee replacements, I've not had that happen. But you have to be aware of it. If someone's had a previous history of blood clots, they're at a greater risk of getting a blood clot from the knee and hip replacement surgery. If someone's 90 and feeble, they're not a candidate. But if they're 90 and healthy and active, they're a candidate. So age is not an absolute factor, it is one factor. Okay? Yes, ma'am?
Does that make any difference if it's osteo or rheumatoid arthritis, the injections? Or
No,
No?
we do both. We see many more rheumatoid arthritis, or many more osteoarthritis. Rheumatoid arthritis responds really well to corticosteroids, so the steroid injections. So we tend to do that, and the rheumatologists tend to do that. Some of the primary care family practice doctor, internal medicine doctors do that, but the rheumatologists do that. And some of the rheumatologists don't like to do injections, they sound to us to do that. And with the rheumatologic or rheumatoid arthritis, the bone quality is an issue because your body's attacking its own bone. So usually we want to cement those in rather than ingrowth those in because of rheumatoid arthritis, but that's not a hard and fast rule at all anymore. Again, rheumatoid arthritis is your body attacking itself. A little bit greater risk of it getting loose after rheumatoid arthritis than with osteoarthritis.
On joint replacement like that, how do you know whether your body's going to rebel against what you have put in?
Well, people don't reject them. That's a term that sometimes patients have. The risk is infection. And if someone has an allergy to nickel, we get a titanium version of the same components in. So if someone says, I think I have a nickel allergy, not uncommon when ladies will come in and say if they use cheap earrings that they get rash around them. That isn't always a nickel allergy. There's everything under the sun in some of those inexpensive costume type jewelry things. But we can have people tested for that. And if that's the case, we use all the metal parts are titanium rather than part titanium and part stainless steel. Okay? But you really don't reject the metal. Your body can get an infection, but that's from bacteria getting in there from the surgery or later on in life. Someone can get a urinary tract infection and get into their joint. Someone can get an infection from having dental work done and can get into their joint. Some people can have colon surgery and get into their joint. So most of us still recommend antibiotic treatment after joint replacements when they have dental work done. There's a little bit of a controversy about that. But if you being on $1.50 worth of amoxicillin prevents you from getting an infected knee after your dental work, I argue that's pretty small potatoes compared to having your artificial knee taken out for 3 months, put back in and not have as good an outcome. So a lot of people, when they say rejection, it's more they're thinking about an infection where your body gets infected on the knee, but that's from bacteria getting in there, either from the air, from a wound, from an infection somewhere else, either pneumonia or in your bladder or from dental work. Okay? Anything else? Designs. I should go back. I didn't do anything on this one. This is an artificial shoulder. So the artificial shoulder has a metal piece with a metal ball. There's a plastic socket on the socket side. This is an artificial hip. It's actually 4 pieces. There's metal inside of the femur bone. The ball that we saw in those x-rays, you take the ball, we cut the ball off at surgery, dispose of it, put this metal inside the bone, and we template people ahead of time to know what size is going to fit them the best, because we want it really tight, because then your body grows into this metal. There's metal mesh on there and your body grows into it. The metal mesh is such a size that your body says raw bone, metal that looks like bone, let's fuse this fracture together. So the fixation occurs from the body growing the bone into that metal. Same with the socket, there's metal in the back, and then the bone goes into it. Then we snap a piece of plastic in that metal, and we have the artificial joint right here, and I'll pass this around. This one's been beat up, so it's not real smooth to move around. It's been used for 25 years as an example. But these are real components. And right away from day one after a hip replacement, you're putting full weight on it with the use of a walker or crutches, getting rid of them after a few days or up to a few weeks. And the picture on the left is an artificial knee. With the knee, we're actually just resurfacing the surface of the knee, and I'll pass this around. It doesn't have the kneecap on this model, but there's a kneecap that has a button on it too. And so with bones, with the knees, so many patients tell me they're surprised that that's all the bone I take away. We're just putting new surfaces on. When we open up the knee, we just take a 1/4 inch off the upper bone and 1/4 to a 1/3 inch off the lower bone and put new surfaces on. And that's the way the knee works. I'll pop it open so you can pass that around. This one has a kneecap on it. Things are changing and evolving all the time. That's another reason that if you were 45 and you're just starting to wear out your knee, chances are by the time you're 50 or 52, there's going to be a newer version of the artificial knees out there that will last longer. So again, technology is constantly changing. The most recent changes have been in the plastic components. The plastic used to wear the fastest. Now they've changed the plastic in that we're putting vitamin E in the plastic, and they're irradiating the plastic, and they're packaging in nitrogen. All of those things make the plastic last longer. Dr. Smedberg's going to be talking next about sports medicine, and Dr. Gallup and Dr. Dillman will be doing some talks.
Before we get to this, any other questions for Dr. Wilkes?
Oh, we need to help with that. So when does it get to a point where I'm like, I don't want to just do this anymore, it hurts more, and then the next step is the cortisone? Where is that line to say?
That line is, I say to my patient, when is it bad enough? When you think it's bad enough, it's bad enough. There's not a black and white answer to that. And that's not to belittle, and I'm saying, if you say I don't want to put up with this anymore, that TV out the window thing, you know, that's the image I get, it's time to just come in and talk about having that done. You may decide after the discussion about it that you don't want that shot yet, but it's a relatively benign thing. I told a lady today that was all worried that I was going to inject her knee because she didn't want to have it done last time. I wanted her husband to be with her to hold her hand. And she said, I didn't need you, she said today, because it isn't all that bad. Shots in the heel or in the elbow hurt a lot more because you're not going into the joint. Into the joint capsule, there's a lot of space to allow for that fluid to be in. It doesn't hurt. Okay?
So what, when you said that some last 2 weeks, some last longer, why is that? Because everybody's different?
Well,
or?
everybody's different, and how much inflammation they have is different, but also everybody's perception of pain is different. Everyone has a different pain threshold. It's kind of like I tell people, is it a $50 fender bender or is it a $5,000 fender bender? You know, I don't ever predict how much pain someone has because you can't look at people and know that. It's so individual and so personal, the level of pain that you're willing to tolerate or can tolerate. You know, 3 generations ago, everybody sat on the porch in the rocking chair and said, yeah, I got my rheumatiz today. Bothered me, you know, the clampets, right? Right? Granny, rheumatiz is kicking in today. The weather's coming, the storm's going to happen. You know, and now it's become so commonplace to have joint replacements done that we say we don't want to live with that. You know, the advantage we have in this country is there is no limitation on the ability to do joint replacements. Canada, each province has how many they can do that year. So if you live in Ontario, you can have there are 10,000 that are done that year. If it's June 12th, the 10,000th one is done, they're done for the year. So you wait 5 to 10 years to have them done. My buddy's up in Ashland, Wisconsin. He does 40% of his knee replacements are people coming down from Canada paying to have it done. Because you got to be on the waiting list so long because it's in the order that you've got to put on it. I'm not preaching that. I'm just saying until we have restrictions on this, you can come in today and have it done next week if it needs to be done. But I want people to always consider the conservative alternatives for the multiple reasons. If a shot works for you and you get a year's relief out of it,
and we can get you 5 years down the road, and you haven't had any risks of the surgery. Even though they're minimal, there's no risk if you don't have the surgery. And you're happier and you're able to do more things and do things with your grandkids. You can ride your bike and do your vacationing. It's hard to argue with that, but you'll know when it's bad enough. You'll know when it's time to go to the next step. And it doesn't burn any bridges. Having the injection, if it works, it's great. If it doesn't work, it can't be undone. It's not like you've gone too far. You follow me?
Mm-hmm.
So there's not a right or wrong. It's really how much it's bothering you. Does that make sense?
Yeah.
Yeah.
Because when Dr. Bellman told me I had
Yeah.
arthritis in there, I'm like, he says, why did you put a shot in there? I'm like, no, I think I'll try something else. So I've been doing the Elite.
I always tell people with you got a little bit of Arthur and his cousin Ritis, both of them are knocking on the door,
So he's like, oh, I
Again,
didn't want to do that at that time, but it's been a couple
You
of years.
can't
now.
look at someone and predict whether they have a high pain threshold, low pain threshold. I'll give everybody one secret. Never walk into a doctor's office and say, my wife has a really high pain threshold. Doctors think it's the exact opposite. Okay? Because the only person that feels like they have to tell someone they have a high pain threshold is someone that has a low pain threshold, right?
Dr. Wilkes, a question over here?
Yes, sir.
You answered some of it over there. The cortisone shots, on your thing it said may cause, I'm thinking that once you starting the cortisone shots, it's going to deteriorate and that, I don't know.
We don't want to do cortisone shots on normal joint with good cartilage because it runs the risk of making that cartilage wear away faster.
It becomes mushy and it's...
Well, it can just make it wear away a little bit faster because we get rid of the repair process. When it's already worn out, it doesn't matter. One of the things I wanted to mention is if you're diabetic, when you have a cortisone shot, you got to watch the next day. Your sugars may go off the wall the next day from the effect of the cortisone because a little bit of the cortisone does get in your bloodstream and it can goof up your sugar levels in a diabetic.
So that once you start the cortisone shot, if it lasts like 6 months or a year, you're doing good. But it's going to slowly deteriorate more and more. It's not going to be. It's never
We're
going to
only
be as
doing
good.
it when it's already deteriorated enough that it doesn't matter.
But your rooster would be much better because I read was like it's a natural. But then there's the cost of what.
Right.
But I'm thinking the.
And if you're allergic to eggs or feathers, you can't have it.
But
I'm serious.
you're better off with rooster because it's more of a natural than, and the natural rooster doesn't deteriorate the.
It doesn't, not that we know of. You're right, and it acts like a lubricant. So some people need the anti-inflammatory effect rather than just lubricant. So it's a horse apiece. It's whatever works for you. We aren't doing cortisone shots routinely on people that have normal cartilage. So you're right, it has potential to wear out faster, but usually you're bone on bone already when we do it. So it doesn't have that effect. Now there are people that I'll do a cortisone shot that I've scoped their knee and they get 80% better, and 3 months later it's still only 8% better. We'll put a cortisone shot in there one time, and that's to reduce the inflammation that I created from the injury called arthroscopy. It's surgery. Our brain says surgery, but our knee says injury. Something came in here that didn't belong here. And sometimes your body doesn't produce enough of its natural cortisone to get rid of the inflammation of the injury called surgery. More?
No.
What about knee braces?
Knee braces. The problem with knee braces is, you see it advertised on TV.
Yeah, I know.
If you're ARP, you can get a knee brace. 98% of the knee braces we put on for arthritis end up in the corner or in the closet or next to the bed because they're hard to put on and off. People don't like them. The only ones that really do anything are a custom fit one that changes the angle of your knee. So if you've worn out the inside, the brace tilts your leg a little bit to the outside, so you're putting weight on the outside, or the vice versa. They're $1,000. And so I haven't prescribed an osteoarthritis knee brace in several years because I've not found that people are very compliant with using them. They become a burden to put on and off. That's called donning and doffing, and then putting them on as donning, taking them off as doffing them. And if you have a worn out knee and you're trying to put on and off, sometimes it's hard. It's hard to recommend that because of the difficulty that patients have with getting good relief. And an off-the-shelf one is less likely to do something than a custom one that we can dial in the correction for you.
Is that what the uploader was referring to?
Offloader.
Offloader?
Offloader. I wouldn't want an uploader. It would up the pain. Offloading means take the weight off the side that's more worn out.
That's the
So if
customers.
you've worn out the inner side and you're bow-legged, as soon as you start to tilt, where does more of your weight go? The weight shifts to that side more, because where does the weight of the line of your weight goes from the center hip to the center of the knee. If you're bow-legged, it's going to go through that side. So the offloader is to stress the joint outward a little bit to shift the weight back to the good side that still has cartilage. That's how it offloads the worn out side. You started to ask something.
Yeah. Can you speak to the activities and/or exercises that help strengthen the knee joint, or maintain a certain level of usefulness of it? And when is an activity? What's the trigger points that says that's not the right thing to be doing? Like, I go downstairs, it's excruciating.
Right.
Should I still make myself go down the stairs because I'm going to build strength over time?
No, that's where I recommend the biking, either recumbent or exercise bike upright, or a bike on the road rather than on a trail. Anything in a pool, water exercise classes are phenomenal, because again, you're buoyant. If you're having trouble with a worn out knee, the weight-bearing, weight on, weight off is going to aggravate that. So do less of that for your activity. Do more of the non-offloaded exercises where you aren't putting all your weight on it. When you're on a bike, you have some pressure on your knee joint, but it isn't all of your weight coming down and all of it coming off. It's worse when there's all on, all off, rather than half of your weight on constantly. Swimming, biking, elliptical, not a Stairmaster, and not a stepper exercise at the gym where you're going up and down the stairs. Those will aggravate the knees. Elliptical, we call them closed chain or open chain. Are you happy with me, Ms. Physical Therapist?
Yeah.
Open chain or closed chain? I'm standing here right now, this is a closed chain, right? We could draw a line from my leg through my pelvis, down my leg, through the floor, back up to the leg. On a bike, it's an open chain, or a closed chain, right? My line could go through my leg to the pedal, across the spoke, to the other pedal, all the way up. Running, open chain, right? We break the chain. Elliptical, closed chain. Biking, closed chain. Closed chain exercises do less aggravation to the weight-bearing joints, the hip and the knee, because you have some pressure on it and you're moving with some pressure rather than all your weight coming on it, all your weight going off. All right, so closed chain exercises, anything that's a closed chain where you could make a continuous line and it's not being open, and all of a sudden I just broke that chain when I do running. So closed chain are more effective when you are hurting in the knees and hips.
And just to follow up on that, so let's say stairs are a normal part of your life. You will go up and down stairs every single day.
And you're not harming yourself to do that. It's whether you can put up with the discomfort.
But should you still focus on not causing problems with ankles or hips by going down the stairs, straight down the stairs normal, or like I sidle down the stairs because I can't take
When my knee, I tore my ACL 30 years ago, and back 30 years ago, I didn't like the way we were doing. We weren't getting many years out of them. I have bone on bone. I'm 61, and I've got bone on bone for the last 4 years. My right one now has become bone on bone, and sometimes I have days where I hold the rail and I go sideways down. Because when you're doing that, when you go forward, your knee wants to unlock, and it's like having a pebble in your shoe. It's called pain inhibition. I can tell you to walk normal with that pebble in your shoe, but when you put weight on it, that pebble hurts. Your body gives away. It's the same when that pain isn't the pebble in your shoe, but the pebble is in your knee. That knee hurts, right? So it wants to give way in this direction. How do you prevent that? Turn sideways, and the ligaments won't let you go down this, fall down the stairs, so you turn a little bit. So it's a natural way to compensate. You do whatever you can to be safer. The other way is, you know how if we go up and down stairs normally, you go up with one, then go up two with the other, then up one and up two. But when you have bad knees, you go one and then bring the other one up to it, and one and bring the other one up to it, one and bring it up to it. On good days, I can alternate. On bad days, I go one and then bring it to it, one and bring it to it. So I understand. I watch my wife, she's the knock-knee one, I'm the bow-legged one. Together, we're both straight. So you aren't harming yourself. You're causing yourself discomfort, but the die was casted. The wear is already there. You're not harming it. You're not making it worse. It's whether you can put up with it or not. But that's where the Cortisone Shots can help. That's the Hyaluronic Shots can help. That's where the Voltaren gel can help. The Anti-Inflammatory book by mouth can help. No narcotics. And I'm so glad that we've had this whole explosion of the media talking about opioid problems. Because, ladies and gentlemen, we are all in that age group, you more so than me,
that we shouldn't be taking opioids because it makes us lose our balance, makes us fall and break our wrists, break our shoulders, break our backs, break our hips. Opioids, the drug companies that were making opioids have lied over the years saying that people won't get addicted. You do get addicted. Studies have shown that 14 days Tylenol is more effective at reducing pain than the opioids. We're using more Tylenol, we're using more Tramadol, we're going back to Tylenol number 3s. But if someone is offering you opioids because your knee hurts, we should not be using opioids for arthritis pain. Anti-inflammatories, Tylenol gel, injections, cushioned heels, restriction of activities, ice. Those are all the right things, but opioids, I can't preach enough. People get put on opioids and we're seeing them in the emergency room with a broken hip and a broken shoulder because they fell. Because opioids sedate and make you less likely to have your balance. Have you noticed that when we were young, we'd be on a ladder and we'd misstep a little bit and we'd do one of these and be right back there. Now when we do, what happens? Right? Well, now put an opioid on that and you go down. And so that's why I can't preach enough. As orthopedic surgeons, we've been on the opioid bandwagon for 10 years, but it's really been a push. 10 years ago, we were being accused as physicians of not giving patients adequate pain relief. Everyone's entitled to adequate pain relief. How do we define that? Well, the drug companies were pushing behind that. They're saying we use the scale, 0 to 10. 10 is terrible pain, 0 is no pain. If they don't get good enough relief, you're not doing justice. So the states and everybody was punishing physicians for not doing adequate pain relief. Guess what created the opioid addiction? We were answering what we were told we had to do. Now we're saying opioids should be used. And they misrepresented the studies about opioids being non-addictive. They absolutely are. The kids are dying every day from opioids. Elderly people are falling and breaking things. So again, if your primary care clinician, whether it's a nurse practitioner, PA, or family practice, if they want to give you an opioid, ask them, is there an alternative of what I could use? Because opioids create more problems as we age, and they constipate terribly. None of us want that, right?
If a person wanted to have the surgery, how booked up are you?
Oh, usually you think it's going to be done in a week or 2.
Really?
Yeah. 2 of us do joint replacements on Mondays here. 2 of us do them on Tuesdays. The typical time is you come in on a Monday. If it's for me, I do Monday morning. You come in Monday morning, have your surgery, you do therapy Monday afternoon, twice on Tuesday, go home Tuesday afternoon.
Well, see, I found the only way that I can actually sleep anymore, I cannot sleep on my side, either side. Sleep on my back, elevate my legs with clothes.
Knees bent a little bit.
Yeah. Then it takes the relief. I can get out of bed in the morning and not just about fall on my face, you know. So otherwise I'm to that point.
Something we pride ourselves with our joint center is that we look to our patients and what they need. And so, for example, this time of year, busy time of year for us with joint replacements. And everybody comes back, after winter, they get outside and, oh man, it's really bad, I need to do something. And they want to get done before summer is all over. And so what we do is we like to try to make sure our patients can be booked within a few weeks of their diagnosis. If they can't, we went together with our surgery department, our nursing, and our therapy, and we scheduled extra days to get people done in a timely manner.
We have reserved days for just doing hip and knee replacements. 2 of us on Monday, 2 of us on Tuesdays.
So we created some extra ones to get everybody done.
How close can you have them? If you got to have them both done, how close can
you? Ideally, 3 months apart. As soon as 6 weeks apart. 2 reasons. I've done knee replacements both on the same day on the same patient 3 times. The studies have shown a greater risk of having heart problems because you lose twice as much blood, twice as much stress to go through twice as much surgery. And people don't get as good of results in regards of range of motion afterwards because they don't have a good leg to stand on, right? Even though both are worn out, and when I get this one operated on, at first this one's a good one still compared to that. So I like 3 months. I usually end up doing them at 8 to 10 weeks. 6 is the absolute soonest. You kind of want your body to get over the stress of the first surgery to, again, your immune system to be built back up, your blood count to be back up, the stress to your heart, the stress of everything. Because even though we call it surgery, It's an injury to your body, and your body has to recover. It's an insult.
Yeah.
It's a controlled insult, but it's still an insult.
You need that time to heal.
And quite often, when you have your first knee done, you do the one that's worse first. Quite often, the other one isn't so bad once you get a good, really good one. And people sometimes wait 2, 3. I did a person Monday that it was 8 years ago I did the other knee.
Do you flip a coin to see which is the worst one?
I say, patient, which one's worse? I go, which one hurts you the most? If it's a toss-up, you say, which one do you want done first? Because we are legged. When we stand and talk to people, we put more weight on one leg than the other. When we go in and out of a car, we go the same way. When we start stairs, you'll know, start watching this. You'll always start with the same one. When you go down the stairs, you always start with the same one. Proof of that is any kicker in the NFL doesn't kick with both legs, they kick with one. We are legged. Okay, so you've got to look at patients go, I never thought of it, but you know, you're right. I always try to stand on this one, but I can't, so I shift to this one. I said, the one that you can't stand on is the one you do first. Okay?
Well, I'm sure we could ask Dr. Wilkes questions all night long, but we kind of came to the end of our time. I do want to tell you that this series is going to be continued. So our next one is August 29th, and it will be with Dr. Smedberg. We'll be talking along with some of our Aspirus Riverview athletic trainers as well. And we're going to talk about sports medicine. A lot of times people think, oh, sports medicine, that's only athletes. Well, in a way, we're all kind of an athlete. We all get injuries from the sport things or things that we enjoy doing. So it can
I'd like to one
benefit
little
everyone.
plug. I would
Sure.
like people to start putting in requests for topics because that would stimulate us.
Yes.
That would stimulate us as surgeons and Kathleen as a director and Lisa as a therapist to look at some other interesting topics. If there are things,
Yeah.
most of us love to teach. I love to be in this situation. I know it doesn't show, does it? I love to talk when you're not under the, I got 15 minutes or I got 12 minutes or I got a patient getting upset that they're waiting for me. In this type of venue, it's really healthy for all of us to talk. Because what I found is every question that you ask, 3 other people in that same room were thinking the same darn question. But there's some of them are, 2 of them are afraid to ask it. So when they hear it, all of a sudden people go, well, I'll ask mine now too. And the conversation breeds itself, and it's really healthy for all of us as a clinician and for all of you. So if there are topics that people would like, I think we should start doing that.
On, on your chairs today, I have a sheet that's asking about if you're interested in talking with me about joint pain and what treatment options are out there. Please give me a call and write on there, great idea. Write on there any topics you would like to see in the
Because if we get 3 people that ask for a topic, there are 30 of them that want to hear it.
Yeah.
We'd be happy to put a presentation together.
If you have ideas, write it down there for me. Let me know. There's my contact information is on there as well. You certainly can send
Does this
me
less formal way of doing it rather than a big computer presentation? I don't like that because I think patients tend to be, I want it to be more like this.
It was very good.
You know, town hall meeting, right?
Yeah.
Well, I'm not a politician. Who'd want to be today, right?
I think Dr. Wilkes did an excellent job. Thank you so much for being here.
It was fun.